sorry about all the words on this slide. It's just to remind me what I do every day. Anyway, you can read it more quickly than I can say it. I just want to put out a few key words about modern palliative care. It's proactive, it's flexible. You can dip in and out of palliative care. When I first qualified as a doctor in the East End of London, at a London hospital, if I referred somebody to the hospice, and there was one of the earlier hospices there, St. Joseph's Hospice, I filled in a form, and they were only accepted if the box was ticked that said I thought they'd got less than 6 weeks to live. Now hospices have gyms and cafeterias, not for the staff, but for the ill people. Okay? So key things on here are any serious disease or frailty and their families, highly individualized, carefully tailored, and then the last 3 points, or last 3 points, restoring hope now and for tomorrow, and facilitating a peaceful, dignified death when that time comes. And it extends into bereavement. Next slide, please. So here we have a slide, and I hope nobody in this room is touched by motor neuron disease. I don't know that. So if you are in any way, I apologize for taking this as an example. But people with motor neuron disease is a group of people who are often cited as people who would want a medically assisted death. So say somebody's got motor neuron disease and their respiratory muscles are weakening. They will die of that. But they have choices, big choices. They can choose, if they wish, to start non-invasive ventilation, a mask on their face that puts oxygen under pressure into their lungs and keeps them alive, at least for longer than they would have had. But if they choose that, they can also choose when to stop it. So there's lots of choices here. And one of the things that gets my goat, or my bee in my bonnet, is the fact that dignity and choice are words that have been sort of stolen away from palliative care, I feel, by the pro-euthanasia and physician-assisted suicide lobbies. And actually, this is absolutely full of choice. So they can choose to stop when they want to. And they can then rest assured that they will be cared for with meticulous attention to symptom control and in a highly individualized way. And any drugs they need will be tailored to them. This is not a pharmacology session, but you think about the age of the person, what's wrong with the person, their body weight, how they are, what their problems are, what their kidneys are doing, what their liver's doing. Drug prescribing isn't just a blunderbuss bang of a big dose of things. Next slide, please. Let's compare that with euthanasia or physician-assisted suicide. Here, somebody it's certainly in track 1, most of the time, the people thought to have a terminal illness, is going to be dying sometime in the next 6 or maybe 6 to 12 months. But they die before that because they're given drugs with the express intention of killing them. So they die prematurely. And to me, these two things are very, very different, morally, ethically, and legally. But there's an enormous amount of confusion about it. And I hope that might have clarified things a little bit.